Hello. So I'm going to try and talk about arrhythmias, pacemakers, and defibrillators. I read up a bit and I got confused. So anyway, so it's slightly haphazard, but I'll try and tell you what I think you may not know, but none of it is very new. But I might have got it wrong because I don't know what you know. So that's me. I'm going to talk about arrhythmias, pacemakers, defibrillators. I've got 20 minutes, and the time starts now. I don't think I have a conflict of interest, but I am a cardiac anaesthetist. So my resources are, you just Google them, and UpToDate is a good resource. I looked at this 2019 guideline from the European Heart Rhythm Association, which is a consensus document, and some of my slides are from that paper. There is another guideline that came out recently, again early this year, guidelines for the management of patients with supraventricular tachycardia. It's 66 pages, and I think you probably should be a cardiologist to read it. And then there's this one. This is old, and this is the ESC, ESA guidelines, European Society of Cardiologists, European Society of Anaesthetists, guidelines for non-cardiac surgery, cardiovascular assessment and management. And I really think we should all print it out and have it with us, because this is a very good document. And this is old, and I think Henry Prashant and I presented parts of it a few years ago. And this is the latest version available. I also took some from, there was this BJA education article on the Preop management of patients with cardiac implantable electronic devices. 2016 is a nice little article as well. So, arrhythmias under surgery, the incidence is between 11 and 70%. And mostly depends on the paper you read and also how you define arrhythmias. Every time you have a little tachycardia on laryngoscopy, if that's an arrhythmia, then you get 70%. So it depends on how you define them. You have a full range of supraventricular and tachy and brady and ventricular arrhythmias. So you can get everything. So when I started reading about this article, I thought, oh, crikey, when am I going to stop? And anything can cause it, or everything can cause it. But the good news is that supraventricular arrhythmias and AF is more common. Almost 90% are supraventricular arrhythmias. Ventricular arrhythmias are less common, but they're more problematic. But hopefully most of us won't see many of them. This is interesting that I think we all know this, but it's worth keeping this in mind, that acute medical conditions, sepsis, respiratory conditions, AKI, acute brain injury, and cancer can increase your likelihood of getting a perioperative arrhythmia. We know about the rest of it, but just cancer, I thought was interesting that you can get complications of cancer. So it can be complications of the tumor, it can be local or systemic. Chemotherapy, anthracyclines, and monoclonal antibodies can give you arrhythmias. And radiotherapy can give you arrhythmias. And radiotherapy also, as we'll see later, has some implications on implantable electronic devices. Arrhythmia management, if you get one in the middle of your anesthetic, is, again, there's this beautiful algorithm, and this is from the Heart Rhythm Association document 2019, and it's fairly simple, and I can't see up there, but anyway, so is the patient not breathing, then advanced life support, and if they're breathing, then, can you see the mouse? Yeah, okay. If they're breathing and hemodynamically unstable, then you shock them, and then you can give them some amiodarone. And if they're not unstable, Then you assess the QRS width and proceed to third panel. Oh dear. So third panel is that. So that's very easy. So you can look and see if your right bundle branch pattern is got, I don't know, RS, R prime and V1, or you can see if they're two P wave morphologies or three. So forget it. You get get a cardiologist. What is worth looking at is the reversible causes. And they're slightly, like 4Hs, 4Ts, slightly more than that, but hypoxia, hypovolemia, electrolyte abnormalities. I'll just read them just so that you can remember them. Acidosis, altered autonomic tone, endogenous catecholamines, exogenous catecholamines, hypothermia, hyperthermia, thrombosis, myocardial ischemia, infection, fever, sepsis, thyrotoxicosis, bradycardias, tension pneumothorax, tamponade, and drugs. But this is what we see most often. So I thought we'd talk about this a little. And I think none of this is new, but I thought it's just interesting because this is what we face almost all the time. Preop atrial fibrillation, you can find pre-op atrial fibrillation. And I didn't know until maybe a few years ago, 2-3 years ago, that the mortality from isolated atrial fibrillation is more than twice that from isolated coronary artery disease. And we are quite keen on coronary artery disease, but not on, and this is non-valvular atrial fibrillation, not valvular atrial fibrillation. The second thing, again, I learned recently, 4 or 5 years ago, is that it increases the risk of stroke 5-fold. So, preoperatively, on top of rate control, if you can't rhythm control them, they need to be anticoagulated. And the message seems to be that people are so worried about anticoagulation during surgery is that they're not anticoagulated enough. So what you use is the CHADS VASC score to check if they need anticoagulation, and only if you score 0 that you don't anticoagulate them. And it says CHA2, DS2 because you get 2 points for age and 2 points for stroke. The maximum you can get is 9 because you can't be between 65 and 74 and above 75. So that is 10, so you can only get 9. And so if it's 0, no anticoagulation. So if the CHADS-VASc score is 1, then you need anticoagulation with at least an antiplatelet. And if it's more than 2, you need anticoagulation with either a DOAC or warfarin. But increasingly, people are suggesting that just antiplatelets are not enough. So if you score 1, you should give them and then anticoagulate them with a DOAC, possibly. That has to be balanced against the risk of bleeding. And then you've got this Hasbled score. And if you, again, the score is a maximum of 9. And if you score more than or equal to 3, then the risk of bleeding is higher than the risk of stroke. So those who read the last 2 slides carefully will notice that some risk factors are in both columns. So it does make it difficult. But the message seems to be that we are not anticoagulating enough. So in this era of perioperative medicine, they might survive your anesthetic, but like I like to say, is they might be a victim of your success, i.e. they get a stroke afterwards. During the perioperative period, you can get AF, and these are the they're patient-related and surgery-related factors. Old age, males get more AF, but you might have noticed that you score higher on the CHADS-VASc if you're a female. Caucasians, comorbidities, history of arrhythmias with prior surgeries, withdrawal from alcohol, hypothyroidism, lots of uncontrolled pain, electrolyte imbalance, hypoxia, hypotension, hypovolemia, hypervolemia, hypothermia, anemia, infection. And you have surgery-related factors, type of surgery, emergency surgery, surgery for advanced lung cancer, and certain studies have suggested, for example, again, I didn't know until I read this, that colorectal surgery has a 26% incidence of AF, and probably it's related to cancer, related to the surgery itself, related to the age, etc. This is just a summary of what can happen with postoperative AF, why it happens: myocardial stretch, myocardial ischemia, increased sympathetic tone, activation of renin-angiotensin, all of which, as you know, as Dilip Lobo suggested, that, I don't know, adenosine does something or the other, but it's good to treat AF anyway. And how do you manage it? Newly diagnosed AF, acute management, clinical assessment, you think of anticoagulation. Again, if you're hemodynamically stable, then you go for rate control. And if beta blockers, diltiazem, amiodarone don't work, then you go for amiodarone and class 1 antiarrhythmic drugs, which is sodium channel blockers. Again, we don't know much about them. That's flecainide, so that's the cardiologists. And if they're hemodynamically unstable, DC cardioversion. So what do we do? In summary, if there's atrial fibrillation, rhythm control with DC cardioversion if they're unstable. I use a lot of magnesium. I think magnesium is good for everything. So bronchodilation, hypertension, and rhythm control. Beta blockers, the books talk about esmolol. Esmolol is a nightmare to use. You have to dilute it, etc. Metoprolol, I think, in the non-cardiac population is not used a lot, and I think you give 1 milligram at a time, and it's very useful. Rate control should be between 50 and 100 per minute, and if the preoperative heart rate is more than 100, then you should consider cancelling elective surgery. And there is some grey area between 100 and 120, of course, there's always a grey area. Calcium channel blockers, they recommend, but I don't know how many of us use diltiazem IV. And digoxin, yes, possibly. It takes about 5 minutes to act, but the peak action is about 4 hours, so it really won't help you intraoperatively. And please think of anticoagulation. If you get AF, and the recommendation is if you have AF for more than 48 hours, you should get anticoagulated. Right. So the recommendations from the European Society of Cardiologists and European Society of Anaesthetists is to continue oral antiarrhythmic drugs before surgery. But as you can see, the level of evidence is all C, so it's consensus opinion. Cardioversion when hemodynamic instability occurs, and vagal maneuvers. And just for completion's sake, for ventricular arrhythmias, again, you continue antiarrhythmic drugs. And antiarrhythmic drugs are recommended for sustained VT depending on patient characteristics, but not recommended for patients with ventricular premature contractions, VPCs. But again, the level of evidence is very weak. So that's AF, pacemakers and defibrillators. A few slides on them. They're not called pacemakers and defibrillators anymore. They used to be called cardiac rhythm management devices until 2016 or something. Now they're called cardiac implantable electronic devices. So the indications of pacemaker, very quickly. So anything with the sinus node, anything with AV conduction, and then further below. Most, or the vast majority of indications are for AV block or sinus node dysfunction. And this is how can you see it? Yeah, this is how a pacemaker looks, classic dual chamber pacemaker. There's a little box and there are leads. But these days you've got these leadless pacemakers, which are good. You don't get infections. You get less infection. You get no tricuspid regurgitation. There's no box to change. All of that is good. The problem is, of course, these are not DDD, or this one isn't DDD, because if you've got to go through the tricuspid valve, then it defeats the purpose. So this is just a sort of VVI kind of pacemaker, ventricular pacemaker. Cardiac resynchronization therapy. These are the biventricular pacemakers. Cardiac resynchronization therapy with pacemakers. And they're generally bad news in that they're only indicated if you have an ejection fraction less than 35% and if you have got a wide QRS complex. And this is how they look, and it's got the right atrium, right ventricular lead, and another lead in the LV going through the coronary sinus. Implantable cardiac defibrillators, indications of a secondary prevention, post-cardiac arrest or post a VT, VF, or primary prevention for long QT, Brugada syndrome, cardiomyopathy, or post-MI. This is not a usual defibrillator. These are new subcutaneous defibrillators. So most of the cardiac defibrillators that are implantable cardiac defibrillators look like a normal pacemaker, and thus the box is bigger, so you can pace with them. So they're called CRT-D. So there was cardiac resynchronization therapy with the defibrillator. These are subcutaneous, so there's no intravascular leads, and they will not pace. Generally, they'll only pace after they've given a shock, and it's like the transthoracic pacing. Pacemaker codes, obviously it's a pacemaker, so the first chamber is the chamber paced, and then the chamber sensed, response to sensing, programmability, which is only to do with rate responsive, and multi-site is to do with dual chamber pacing. DDD is the most commonly used mode. VVI you can use if there's AF with a slow ventricular rate. AAIs if there's sinus bradycardia with a normal atrioventricular conduction. And VAT is AV block with a normal sinus node. These are the commonest. And temporary pacing is AOO and VOO. Pre-op assessment, look for syncope, palpitations, confusion, chest pain, heart failure, or hiccups. These are red flags in that the pacemaker is not working properly. Mark Lyons is the electrophysiologist who's produced this guideline, and this is available, and it's very simple, really. If you've got a loop recorder, then you do nothing about it, and there's no interaction. Otherwise, if it's an ICD, then you need to turn off the tachycardia functions. We used to suggest that if it's a rate-responsive pacemaker, you turn the rate responsiveness off, but that's not recommended anymore. And if they're pacemaker dependent, then they need a pre-op check. If they're not dependent, then no reprogramming is required. Pacemaker dependence, the definition differs. In our hospital is if there's no underlying rhythm. But in most places, if the underlying rhythm is less than 30, they say they're pacemaker dependent. Intraoperative considerations, make sure you monitor heart rate, ECG, and another monitor. Temporary pacing, consider temporary pacing. We talk about the magnet, electrolyte and acid-base imbalance, hypothermia, hyperventilation, and think about electromagnetic interference, which is the diathermy, and think about infection. So especially dependent on what surgical prophylaxis you need, because the cost of infection is very high. So if the pacemaker leads gets infected, the mortality rate is 35% for the patient. So it's really high risk if they get infected. I've taken that off because they're not encouraging transvenous pacing at all. So it's either transthoracic or they'll need transvenous pacing if they need it for any other indication. That's irrespective of surgery. And then you must wonder why you take them to surgery unless it's emergency, obviously. Responses to diathermy, it can inhibit the pacing or it can cause asynchronous pacing. Asynchronous pacing is not bad, but although it can cause RONT, but inhibition of pacing is a problem. ICDs can cause inhibition of pacing and asynchronous pacing. It can shock inappropriately or not shock when it should shock. So diathermy recommendations is you give bipolar diathermy, use short bursts, and harmonic scalpels are good, and then you keep the current pathway away from the leads, right? Magnet. So the magnet will, if you've got an ICD and you stick the magnet on, then it'll take away the anti-tachy function. So it will not defibrillate. Some pacemakers are good in that when you put the magnet on, they'll beep or there'll be a tone which will tell you constantly that the magnet's on. And you take it off and it's done and it goes back to the ICD. But most pacemakers, if you stick a magnet on, will go to asynchronous, but some of them will go to asynchronous only for a while before going back to baseline functioning. So you need to get a pacemaker technician involved. And this is what I've just said. I still got time? 2 minutes? I'm almost done. So main considerations, MRI and TENS. Both of these are contraindicated. There's some issue with breast tissue expanders because apparently they use a magnet to search for a needle, and that can interfere. Radiation can interfere, as I said before. ECT is usually safe, but they suggest after ECT and lithotripsy that you get the pacemaker box checked afterwards within a month, even if it's working properly. And radiofrequency ablation can interfere with pacing. MRI, so MRI is a problem. So all the new pacemakers are MRI compatible. So in the hospital from 2016 onwards, all pacemakers implanted in NUH are MRI compatible. But that doesn't solve the problem. Their previous pacemakers, the leads are not MRI compatible. They might have a box change, so the box might be MRI compatible, but the leads which have been put in 90 may not be MRI compatible. So MRI compatibility is still a problem. And the pacemaker check afterwards should make sure that you restore deactivated functions. You check the pacemaker threshold and look for battery life, but Mark will do it. So finally, recommendations on bradyarrhythmias and pacemakers from the ESC/ESA guidelines. Indication for temporary pacemakers during perioperative period are generally the same as those for permanent pacemakers, like I said before. It's recommended that the hospital nominate a person who's responsible for programming of the implanted arrhythmia device, and the person is Mark Lyons, and he's very friendly and he's a nice chap. And patients with ICDs whose device have been deactivated should be on a continuous cardiac monitor throughout the period of deactivation. And external defibrillation equipment should be available. So basically, but they are very good. If you tell them, they'll come and they'll reactivate it in recovery. But you just got to give them a couple of weeks' notice for elective procedures so they can set their diaries, sort their diaries out. Thank you. Any questions?